Mm-hmm.
All right, we got 30 seconds.
Okay.
All right, good evening. We are all set for the live broadcast stream of today's Health and Human Service Committee meeting at 6 p.m. on HPA-TV, Comcast, and Frontier Government Channels 96 and 6032. It would also be streamed via HPA-TV, the HPA-TV Facebook page, and HPA-TV's Roku TV, Apple TV, and Amazon TV apps. It will also be rebroadcast and made available on the HPA-TV YouTube channel. So thank you everyone for attending. With us this evening, we have voting member Councilman John Gale. We also have voting person, Councilwoman Rossetti. We have Councilman Josh Michtam. We have Attorney Damar Osborne. And last but not least, Director Liani Arroyo. So the first item on the agenda this evening is a Mayor Bronin with a company resolution authorizing the mayor of the city of Hartford to accept the additional $1,342,290.16. Can't forget the 16 cents in funding from the state of Connecticut's Department of Public Health. And so, Director Liani, I believe you are here to talk on the item. So the floor is yours.
Yes, thank you. So the ELC2 grant is a grant that the state of Connecticut received from the Centers for Disease Control and Prevention. It is essentially a formula grant that the state has provided us. The period is March 1st through February 28th of 2024. It had a shortened period. They've just recently expanded that budget period after we submitted this. So it will be for a 2-year period. This funding is about increasing our capacity here internally to continue to monitor the COVID situation. Lots of things have changed from when this was first submitted and we were first provided this funding. And so we are in the process of reworking lots of things with the state, but essentially it will help us to set up testing here in the city. As you're all aware, funding at the federal level is going away. So we'll be using some of this funding for testing. It will likely support some partners in helping us to increase testing capacity as needed and expand that and contract that. And also because just of the move towards looking at this as an endemic versus moving from the pandemic to an endemic stage, there's going to be a need for a lot of education here in the city, and there's going to have to sort of be this constant sort of education of our community members as things change. So as I've told you before, you know, I can come in front of you one day and 2 days later the information is different. And so we also need to make sure that we're doing that and keeping our community educated around this. And so a lot of this, again, is about building capacity internally to allow us to continue to do this work and to be able to monitor and help keep our city safe. There are, you know, we're having additional discussions around how testing can look like in the future when we have surges and things like that. So that's money will go to support that and to support the COVID team that we currently have in place to continue clinics and continue education and expand now into testing as well.
Thank you, Director. So I'll open up the floor to any of my council colleagues. Anybody have any questions? Councilman Gale.
Thank you, Mr. Chair, and thank you, Director Arroyo. Always good to see you. Dr. Arroyo. So first question, was any of this money incorporated into last year's budget? And that is, did you anticipate receiving this, or is this all new?
It should be for this upcoming year's budget. And we didn't incorporate it into this current budget because it was new money. It was not accounted for when we did our budget for FY22. I guess is what we're in, or FY21, which is what we're in. Sorry. That was
no,
not.
it's 22 we're in.
20. I'm so sorry. I'm like looking at budgets.
It took me years to understand it. Not to worry.
I was just explaining it to someone else. No, it's 22 because you're looking at the year ahead. Okay, so it's FY22. That was not accounted for in this year's budget because we did not receive this notification until once that budget had already been submitted and approved. So the way we're sort of layering this, there's lots of money that has come in and it all needs to be used by certain dates because it's time limited. And so we're looking at really bringing this funding into play into this upcoming fiscal year because we're spending down what we call ELC1 funding now. So it'll sort of layer upon the money that we have and allow us to continue the work that we're doing and expand that work in different directions rather than trying to bring a lot of new people in and do a lot of things right now when we have 2 years to use this money. And we also don't know when this additional funding may come available. We just know that we have this funding right now, and we're trying to make sure that we can use it as judiciously and in the best way to make the best impact from here through 2024.
And so thank you. So we'll be seeing this in the budget that starts July 1. That's when you'll be using
yes, sir.
money going forward. And that'll give you about a year and 9 months or 8
yes,
months to spend it all. So second question, I think actually gets into the second item on the agenda, which is going to be your sort of COVID update, but this seems very timely. What can you tell us? What is the expectation? I mean, I know you mentioned education, but I guess the question all inquisitive minds want to know is, are we looking at the, realistic potential for a surge? Are we looking at a realistic potential for having to go back to masks, going back to, social distancing, putting a mask mandate back on going indoors at restaurants? What do you foresee in the next coming up summer into fall here?
So I wish I had a crystal ball because then I could play the lotto on this one. But that being said, I think we're going to have to live with some uncertainty around a lot of this. We believe this is going to be sort of a cyclical, more winter type disease. We see our biggest surges in the fall, but that doesn't mean we haven't seen surges in the spring or late summer. It does happen. Last year around this time, we had a surge as well. It was not a huge one, so there wasn't a lot of movement, but there was a surge around this time last year. And so I expect that we're going to see the numbers increase. By how much remains to be seen. We have a lot of people in our city. Natural immunity doesn't necessarily protect you from getting infected, but we know that vaccine and natural immunity together does have some protective factors around this, or at least minimizing how serious of a case of COVID you might have. And so, we're sort of at the tail end for some people of that immunity, of the first individuals that got sick with that first wave of Omicron that we had. Like mid-December to late December was when we really saw the numbers take off. Those folks are sort of coming into their time of their 90 days of presumed immunity. We know that there's antibodies last longer than that, but what that all means, we still don't know. But there's, some level of immunity that may exist in those individuals. So, what we're thinking right now is we have, as a whole, as Connecticut as a whole, we have a highly vaxxed population. Here in the city, we're just almost, we're slightly over 59% fully vaccinated. We saw a larger increase when there's waves, when we have surges, we see interest in vaccination go up quite rapidly. And so that's what we saw over the fall. I mean, in sort of the late fall, early winter, within about 8 weeks, we went up 6 percentage points in people becoming vaccinated. So we're seeing that interest continue. As people hear about the potential for another surge or an uptick or a wave, whatever you want to call it, I don't think it's going to be really a surge or a wave. I think there's going to be a slight uptick that we'll see. There's interest again in vaccination, so we'll continue to work on that. But I think in terms of like mask mandates and all of that stuff, it would have to be really high numbers again. It's a level of sort of balancing things here. It's balancing public health, balancing personal responsibility. It's a balance of both in this case. And I think right now the numbers are low overall. We're seeing increases in vaccine uptake, which we want to continue to see, and we will continue doing this work. For us, this isn't work that has ended. Our vaccine clinics continue. I don't foresee that in the near future of making a recommendation to the mayor for a mask mandate. I think that this is something to have as a tool in our back pocket if the numbers really go up again, to be able to do that. And I would say just myself being in the city and being places and going, you still see people wearing their mask. I think that's a great thing. I myself will wear a mask in a crowded situation indoors. I think it's the safe thing to do right now, especially as there's talk of the potential for, BA2 being here. We know it's already the majority of the cases here in the state of Connecticut. We haven't seen, we saw just our numbers go up from the first week of the reporting period to the second week of the reporting period that ended last Sunday. Only went up by 5 cases. So the numbers are not that high. I hope that we continue that way, but I don't see at this point making a recommendation for a mask mandate in the near future unless we're seeing Omicron-like numbers again.
And so I take it that, and it's my last comment, I take it that the real thrust here is just going to be to continue to make sure that everybody just gets vaccinated, but then gets boosted on a periodic basis, so that you're never going too long without having the protection, thereby, when you do get sick, it's modest, keeps the hospitalizations down and whatnot. I take it that's going to be the thrust of what you're looking at.
Absolutely, and that's the thrust of what we'll be using our ELC funding for. It's really keeping our capacity going to look at trends and to monitor and to work with the schools and contact tracing. The CDC has recommended that be discontinued. We still have some contact tracers from the CDC. We're looking at this as education for our community. We're going to call them. We're going to ask ask the questions. But really, are you being have you been vaccinated? Have you been boosted? If you haven't, here's information on how to do that. This is why it's important. So we're going to view this as an opportunity until those contracts wind down for the contact tracers that we have, and then just continue to work on if there's outbreaks. That's where we'll be focusing our efforts to make sure that we mitigate any outbreaks in businesses or in schools or anything like that. The hope is that this vaccine can get to a point where we have enough information about how long the antibodies last, how long you can go between doses over the next couple months, maybe to a year. We have that information, and that this gets wrapped up into another vaccine that we may have to take. So for those of us that get the flu vaccine, if you remember, the last sort of pandemic that we had was H1N1, the swine flu. No one talks about it, but that vaccine is within the flu vaccine that you get every year if you get your flu vaccine. It's been part and parcel of that vaccine. So I think there are, I'm not sure which pharmaceutical, but one of the pharmaceuticals is working on putting it into the flu vaccine. So it becomes something that we know will protect our most vulnerable, which are our 65 and older population, which very much get that flu vaccine. It's part of, if you're on Medicare, it's a big part of how doctors get graded, I say, but get evaluated on that, and the health centers get evaluated on how well they make sure that their Medicare population gets their flu shots. And then we also know that children here under the age of 6 in the state of Connecticut are also required to get their flu shots. So we know that your very vulnerable populations can be protected with that. So that's the goal of trying to figure out exactly how long we can go between doses, and then if it can get wrapped up into a flu vaccine, then we'll be good. But there's always, again, variants that can happen. That right now we've been lucky that the variants, Omicron was more transmissible, but it didn't seem to be more virulent. BA2 seems to be going along the same way. It's more transmissible than BA1, than the original Omicron. but it doesn't seem to be as virulent, which is a good thing. But we also have a population here in our state, in our city, that have high numbers of individuals with comorbidities. And so that's why it's important for us to continue this outreach and education to ensure that they understand that it's important for them to remain up to date on their COVID vaccinations if they fall within one of these categories that would make them at risk for harsher outcomes.
Thank you.
Councilman Mickham.
Thank you. Director, you mentioned just now a balance in terms of mask mandates, a balance between protection and personal responsibility. And I guess can you just explain that a little bit to me? Because I don't know, from my way of seeing it, there's no downside to having a mask mandate, maybe when you don't absolutely fully need one. Like, what does that balance mean? Why not just err on the side of caution?
So I bring up balance and as part of, if we continue to keep masks on, look, I think in a perfect world, this would not have become politicized. It became very politicized, right? So let's just, cards on the table. I'm not gonna hide from that or shirk from that. I think in a perfect world, it would not have become politicized. It would be a tool that people feel comfortable continuing to use. And that it wouldn't have become so divisive. We don't live in a perfect world, and this is what it became, right? And so when I think about sort of big picture of how we have this tool in our toolkit, and not to necessarily overuse it, because it may have to come back at some point in time, and it may not be for COVID, it could be for something else, right? That there's not that sort of hostility towards having it, being able to use it again. We go by CDC guidance. That doesn't necessarily mean we always agree with CDC guidance as public health practitioners, but we have agreed I have agreed that is going to be, if I'm going to follow them when they're saying one thing, then I also need to be working and following them when they're saying something else as well. And so I think in this case, there's not, what they're saying is not without issue, but I think overall, I've come to my own conclusion that if this is a tool that we may have to use again in the future, that I want to make sure that we can use it when it's absolutely necessary to do it. And you're right, there's not a downside to, if you want to keep your mask on, keep it on. Like I said, when I go into a situation and I don't know who's in there and that I will put my mask on. If I'm in a situation where I know people, I don't wear my mask. And you're talking to a person who used to wear her mask around her mother and her family for a long time. So it is a challenge, and I don't want to sort of shy away from that or say it's a perfect answer, Councilman. But that's sort of, I think, right now where I've landed in looking at this. We have testing a capability both from the state and within our region. We have home tests. You'll be receiving some information about that shortly. And there's home tests that are available not only from us, but also from the federal government. We continue to put that out. We're going to be doing some new educational literature on the importance, as I'm constantly asking our partners about what's the data, like how many people are you giving monoclonal antibodies with that are from Hartford, that are people of color, that are higher risk. And I think you all just saw recently a new report that we're less likely to get monoclonal antibodies, we're less likely to get the antiretroviral. So I'm working with my communications person to do more work around that as well, so that our community knows if you have COVID and you have one of these diseases, or you start feeling some of these symptoms, you need to call and get tested immediately, call immediately, and get antiretrovirals or monoclonal antibodies immediately. And these are the things that you need to say in order to get them. So we're working a lot on making sure that we do that.
If I could have just one quick follow-up. Is there a threshold in terms of, and forgive me if you said this before, because you said a lot of things with a lot of numbers. Is there a threshold in terms of the trend of transmissions or cases or percentages where you would say, all right, now we are going to impose either, any of, like, is there a place where you say mask mandate and a place where you say remote school and, any, like, have you figured that out already?
So, we've had these conversations with the state, and there was a big push initially to have these sort of metrics. It's hard for me as an individual to say this is how we should do it if no one else around, right? Because there's so much cross-border that we do, right? You think about our children, they're crossing borders to go to school. I have one child in CREC, one child in HPS, one's in Avon, one's in the city of Hartford. So it's hard to make these kinds of decisions as an individual just for the city of Hartford, knowing that there's all of this sort of, regionalism in many ways for jobs and for school. So I've not come up with numbers. It is an ongoing conversation. Right now, what I will look at is what the CDC has put out as their best guidance at this point in time, which is if you go up in the colors on your new map, then those will be where we start having conversations. And that map that they now have that we're green under, both as a county, because they look at it as a county, but I look at it as a city as well. As a city, we're also green. Would be really, it's focused on both, it's really on hospitalizations and hospital capacity, but there's also right under it cases. And so in an event that even though hospital capacity was great, but we're just out of control in cases, and that would be a conversation. I will look at the data, I would look at where these cases are coming from and have that conversation with the mayor, but it's not necessarily a number. I can't say at this number I would do that. And I think our schools have done a tremendous job in keeping kids safe. And I think we show that you can keep kids safe in schools. Even when they went full in with less than 3 feet, they've been without masks. We're not seeing there's not like high numbers. I meet with the schools regularly. I'm seeing those numbers even now with the mask off. We're not seeing these huge increases in numbers that we were afraid of, even with BA2 being the dominant thing right now. I think more kids are getting colds. There's flu going around since they've taken off their mask, but we haven't really seen something that I was very fearful of, which was those increases in cases. And I think they came off at a right time. And I'm hoping that we make it through the end of the year without having to recommend that mask go back on. But again, if we start seeing crazy cases, it may be that a particular school needs to put them back on. It may be that a particular classroom, like there's other ways that we can handle that if it's just affecting one particular school.
Thanks.
Any other questions, Councilwoman Rossetti? I want to afford you the opportunity. Okay, so a lot of the questions kind of go through agenda item 1 and 2, but I'll go back to this grant specifically. So in the resolution, it talks about paying salaries and benefits. How many how many employees are we talking about?
We currently have two FTEs that are being paid by this. We are contracting. We haven't had success in finding a nurse, so we're doing some contracted services for nursing right now. And we're looking at bringing in at least one other position to be a part of this. And then that's it where we're at right now. And then there's a contract for CHWs. We have a contract. Initially, we had multiple contracts, but that has now been consolidated. We have one contract with the Hispanic Health Council at this point in time to do services, and through ELC1 and through ELC2, we're looking at contracting with another agency that has CHWs as well, to have a larger group of community health workers that can help with education and testing, and if contact tracing if we need to do it in an outbreak investigation.
Great. And I guess the question I would have is that outside of this ELC2, in terms of sustainability around jobs, what would be the plan after this grant runs out? Or is it just kind of a position based upon grants? Will we transition those people to other positions? How do you foreshadow that working?
So these individuals have always been on grant funded positions. in the event these grants, like, they're not going to be refunded probably. Like, let's just be honest, this is one-time funding that we're getting. It's a lot of money all at once.
Right.
But we will always continually look at new grant opportunities and transfer people over. That's one thing that we always try to do. I don't think since I've been here, we've not let someone go because a grant has ended. We have always found another grant to put them on, and move that. And they are in a union where they do have bumping rights, so they have bumping rights. So if something were to come up, they can bump somebody if needed. But we've never been in that position where we've had people be bumped. And the other positions that we have, I think one of the positions may be in one of the unions that doesn't bump people, but we've always been able to find ways to keep people on, and that's what we would do.
And that's, I just want to give kudos to you for that, and that, folks are connected to maybe particular initiatives or grants. And obviously the big one the last 2 years have been the pandemic. But as we're going to an endemic, and as a society, we all want to head in that direction, job security becomes ever more present, right? And so kudos to you for finding, opportunities, and under your watch, no one getting laid off, and you're hustling to, make sure people have that in place for themselves and their families. So thank you.
Yeah. And that's part of the reason to be upfront with you all, is we don't load up on a lot of positions, because it's easier for me to try to find a space for 2 people than it is to find a space for 7 people on staff. And so that gets a lot harder to do. And that's just, frankly, pressure I don't want to have 7 people's livelihoods depending on me. But we have had those conversations, and as grants end, we meet with them, and we have those conversations, and we also help them find other jobs if that's what they want, if they don't want the job that we have available. But I see Councilwoman Rossetti.
You saw that? No, I must make a comment on that, Director Arroyo, because, first of all, grant funding, it's a blessing and a curse. And when, to your point, and I really appreciate that you say that, because we always talk about when influxes come in, are they sustainable? And I think it's harder to do what you're talking about. It is easier to just say, okay, we have this, we'll do this, and then figure out the aftermath. So I applaud you for thinking about it in that way, because it's just better, not only for the people, but in the long run, there's really some sustainability there. And I really appreciate that. Thank you.
Thanks. And I will say, just so that everyone is aware, when we did these contracted jobs for our CHWs, I did mandate a minimum payment in terms of hourly payment. If they had benefits, or if they didn't have benefits, it was a sort of a mandated minimum that I asked that they adhere to, because we didn't know if these were going to be permanent jobs or not, and so I wanted people to be able to make a living wage at that point in time. And so these are jobs that are comparable in pay to the level and position that they would be here at the city. So those individuals are getting compensated, I think, at a rate that's fair and that is comparable to what their position is in other agencies.
Thank you, Director. All right. Any other comments or questions? All right. Seeing none, the chair will entertain a motion.
Second.
I moved it.
I make a motion to accept I'm sorry, I don't know what I was thinking. I make a motion to accept the resolution. I don't have it in front of me.
ELC2.
ELC2.
That.
Okay.
Yes.
And I second that motion to send it back to council favorably.
Favorably.
Thank you. So all in favor, say aye.
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 Aye. Any opposed? All right. Seeing none, so move. ELC2 moves back favorably. So the second item on the agenda, and not to hold you too much longer, Director, as I know that you kind of interwoven the conversations around COVID with this first item, but the second item on the agenda is to just give us an overall update as to, it seems like we have a light at the end of the tunnel, and that we're heading in that direction, and that although politics come into play, I know your head is clearly, on the health of everyone. And so, God willing, we'll end up in this endemic situation. but I want to provide you the floor to give us an update on COVID.
Great, thank you. So, we're in a much better place here right now in the city, and really proud of the work that our team has done around this. So, as I noted earlier, we're at 67.42%, still low compared to other municipalities, but we have seen a large jump, particularly during that 8-week period during Omicron. People were coming in, to get boosted, they were coming in to get first doses. And we even saw a little bump in spring break with the kids because parents are traveling and they're going to their home countries and they have to be vaccinated to enter the country. So I think some of those things are helping us, but we have 67.42% first dose coverage. We have 59.2% fully vaccinated. We're seeing our boosters are still low. We're only at about 24% boosted. But amongst the population that we know is most at risk, that's 65 and up, they're at nearly 64% of them have received a boost. So that's really good. And we're not differentiating at this time. The data doesn't differentiate between the first booster and the second booster. Second booster just started. So I think we're safe to say that the overwhelming majority, maybe a couple dozen, are second boosters, but that the overwhelming majority of these amongst the 65 plus population are the first boosters. Our lowest numbers in age group is that 5 to 11. We knew that it was going to be a sort of long slog to convince our parents about our 5 to 11-year-olds getting vaccinated. And I think a lot of that has to do with sort of the lack of cohesive messaging that we received from the CDC and the federal government on this. It was, it's like a flu. Oh, everyone needs to be vaccinated, or, kids do well, but oh no, now we need everyone vaccinated. It's sort of like these mixed messages. And I think parents are wrestling with that. We're only at 27.8% first dose coverage and just below 22% fully vaccinated amongst our 5 to 11-year-olds. So we're continuing to work on that. And I think you all saw last week, working with Hartford Public Schools, we did an all-out blitz with Griffin Health. They were the vaccinator. We helped canvas. We helped do some publicity around that. An all-out blitz at 35 schools. Every night there were 5 to 7 schools that had vaccination clinics. And I only have the numbers through Thursday, but they did, I think, 274 vaccinations, which is a good number. It's a solid number. They were doing kids first doses as well, but they were also doing boosters for adults. So we are looking at how we can continue that effort and that work. In terms of where we're at, our numbers right now, we had 51 cases combined for the last 2-week period that was reported. That was reported last Thursday, and that would take us through the day, through the 26th. So that's the latest data that we have. I'll get an update for last week later this evening on what our numbers look like, if they're up or around the same. But the numbers have stayed fairly low. We're starting to see increases in other parts of the state. We should expect that we should see some of those increases here as well. It's a natural fluidity. I'm seeing it come up from the 95 corridor. Soon it'll hit the 84 and we converge. We'll start seeing it, but I'm hoping again that those numbers will be significantly lower than what we saw before. Our test positivity was 1.4%. The numbers of tests was about 5,200. So it was around the range that we've been before. And to have a test positivity, that was great. Again, not to discount the fact that we know there's a lot of at-home testing that's happening. The way testing is being reported is changing as well. So I think we're not going to always get very accurate numbers anymore, which is going to be sort of part of the issue with to Councilman Mickham saying like this is the threshold.
Director, can you make a comment on your opinion on following of infection rates versus positivity?
So positivity is dependent upon how many tests are taken. And so if you don't see a lot of tests that are happening in a really high positivity, we're not testing enough, because that means we're only people that are sick are getting tested, right? You tend to want to see a good number of people being tested and that positivity being low, because then you're testing enough people. It's not just sick people that are getting tested. So it gives us a good idea, but again, it's not it's not the be all and end all. It's wrapped up with a lot of other things. For us, the case rate is important as well. That's always a better indication for us right now. Our case rate is 3 per 100,000. That number's probably higher when you think about at-home tests, but the fact that we're not seeing huge outbreaks, like I'm not getting reports of outbreaks from the shelters, I'm not getting any reports of outbreaks at businesses or anything like that, it leads me to feel confident that even though the real number may be higher than that, it's not so significantly higher that we're missing a lot of information. But it's something for us to keep in mind as things go on. I know one of the other things was around long COVID. So again, it's sort of a new and evolving field. There is, a couple of studies that have come out around January, and I think a new CDC one that I was trying to see if I can glance at before the call. I didn't have an opportunity to, but New York Times put some stuff out in January about long COVID. Some things that I don't really know how to explain. I don't necessarily understand it all, but there are certain things that are related to the possibility of people having long COVID. Some of it is comorbidities, some of it is reactivation of the Epstein-Barr virus, and some other stuff. But I will definitely, pull some more stuff together and see what I come up with. Again, I did mention the fact that we do have a population that has some comorbidities or risk factors that make COVID, can create worse outcomes for us for COVID. And some of those seem to also be related to the possibility of long COVID. But we've also read and have seen that if people get vaccinated, it seems to help with some of the long COVID. So, I think where this all ends up, again, it is a very real thing. People are dealing with some symptoms for far beyond, but what exactly that is, we don't seem to have really great information. It's just new emerging information that's coming out. But again, this is going to be a cyclical thing. We're going to see it. We're going to see it in the fall. How much of it we're going to see, we can't predict, but it will be a cyclical thing that we're going to have to keep an eye on. And for us, it'll be flu campaign along with COVID campaign. Like if you're not vaccinated, come get vaccinated, don't risk it. And then continuing to message the boosters to those populations that are particularly most at risk for bad outcomes if they're not boosted. And I'll stop there.
Yeah. Any other questions from my colleagues? Councilman Mickham?
Thanks. I just wonder, Director Arroyo, heard a lot in the news about like the wastewater monitoring as a way to get a better sense of infection rates. Is that, when you talk about infection rates, is that what you're talking about, or is that something else? And are we looking at that too?
So MDC was a part of it. They're not a part of it now. I'm circling back to CDC has stopped taking applications because of the funding issue that we all know about. I think once this funding issue gets resolved, I'm going to reach out to MDC to get them as part of this system. For us, the wastewater, it's useful, but not as useful as it is for like a New Haven, because our wastewater is 400,000 people and we're a community of 122,000 people. So if we had our own wastewater treatment plant, it would be very different, right? Like I believe New Haven's wastewater is New Haven and Hamden. That is real good data for them because it is there. Bridgeport's is divided into I think east, west or something like that. Again, and it really just covers their area. So that, again, that's really good data for them. For us, it's a little harder. I think it's not, you can't collect, it's getting all mixed in the sludge at the treatment plant where it's being collected, and it's mixed in with Wethersfield and Rocky Hill and Newington. It's not just Hartford, so it gets a little harder to determine the utility of it. But it is still a useful sort of alarm for us, because before people get sick, you're shedding virus. And so for shedding virus into our wastewater and that showing up, then that gives us an indication that it's coming, but we don't have that right now. They were a part of the Yale study, that funding ended, and now CDC is continuing to find new, but they've put a stop to it until the funding situation gets taken care of.
Any other questions? All right, so my question, Director, particularly curious about this long COVID. The first question I have we seen in the past with flu, these long symptoms, or has there been any history in other flu, like swine flu or other flu types with the long
Not that I'm aware of. Not
Yeah.
that I'm aware of, Chair. Definitely that, not that I've heard. I'm happy to dig a little deeper, but that's not something that I'm aware of. But again, this is a new and novel thing. And so we know we are seeing people that have gotten COVID and are now testing with diabetes that didn't have it before, right? So there's lots of things that we're figuring out right now. But in terms of other illnesses, I mean, the flu can lead to other things that can become long-term, right? But as a whole, is it something that we attribute like long flu? It's not something. It would be, some sort of bad outcome that you get from the flu. We wouldn't necessarily consider it long flu the way we were talking about COVID. And it may be that over time, we see that COVID just creates another disease that now we don't call it long COVID anymore. It's just a side effect of having, and we'll figure out who are the people that are most at risk for that and then monitor them. But right now, one of the big things is diabetes and heart problems for people that have both mild COVID and have had that, severe COVID, that doctors are now getting more information about that and being more in tune to that.
So the second question I have is in terms of these long COVID. So is it that I understand the symptom piece, right? Like they didn't have a particular set of symptoms prior to having COVID. And then once they had COVID and potentially recovered or are in recovery, that they still are symptomatic or have some symptoms. So I guess the question I have, would they still test positive? One, and then number two, are they still subsequent to being contagious to, let's say, their colleagues or their people at work? Like, how does that work?
So the answer to the first part, are they still contagious? It depends. In most cases, they're not. I would say test positive. Let me say that. Testing positive was the first question. Test positive, it depends. We have seen people test positive on a PCR test for up to 90 days past, right? So that's why the CDC gives a recommendation. If you have gotten COVID and you need to test, getting a PCR might not be the best thing because you can still test positive. That does not mean you're infectious. So the CDC, that's one thing we do know is they have done testing on this, and they know by every day what's the drop off in percentage of people that can still be infectious. All right. So that drops off to near zero at day 14, which is why at first we had these 14-day quarantines. Right. But you can still test positive. That does not mean you're infectious. And people with long COVID at this point in time are not known to be infectious. Yes, things will depend if you're infectious past the 14 days. If you're someone with a weakened immune system, you may continue to be infectious for a longer, you may be longer than 14 days. But generally speaking, the answer to that is there's no risk. If you have long COVID, there's no risk to your colleagues.
Thank you for that. And one of the things I do want to highlight, Director, is that the goal, like using a sports analogy, which I know some of my colleagues don't like, but it's sorry, I'm simple sometimes, but it seems like the goalpost is constantly moving, right? And I want to thank you for clarifying that for us, because you take down all of the stuff that's on the landscape, CDC, state, and you kind of break it down for us, and you always have been, and you've been the leader and kind of the beacon in that way and providing that leadership for the city. Like, we get all these messages, and so, we get in it from multiple places, and you're able to kind of filter that through and provide not only direction on the way that we as a city are supposed to head, but also for the individuals, from the seniors, the at-risk populations, and those things. And I just want to commend you. I know we're coming at the endemic. I always say that your daughter said that you're going to solve the pandemic, and you always made that commitment to her. And so I was able to see her and see them a couple of weeks ago, and I think about that all the time. And I want to thank you for leading the way for all of us. So the next thing is, and I'm gonna ask this question firmly with tongue in cheek. Okay, where's Dr. Fauci? Where's he at? Like, somebody got to work on his marketing. Like, he's not nowhere to be found anymore.
I have him on my lanyard. I have his face on my lanyard.
Yeah, I mean, I guess if you don't see Dr. Fauci, I guess things are heading in the right direction.
Councilman, he's tired. He's tired.
He's tired.
He's resting up.
He's got
Listen, I think I'm a Fauci fan. I've been a Fauci fan for a long time. Before everyone else knew who Dr. Fauci was, I knew who he was, and I was a fan.
You're saying you knew him before he was cool?
I knew him before everyone wanted to like Fauci. There's several people, and you're in public health. There are certain people that you just kind of know. He's one of them. Dr. Francis Collins, who recently retired from NIH, is another one of them. So there's quite a few people that are folks that we follow if you're in public health. I will say this, I love Dr. Fauci, but there wasn't a coordinated response or a coordinated communication from the feds. And I think we all suffered from that, right? And I think that was one of the downfalls of the federal government. Having worked on swine flu H1N1, in 2004, we had a very skilled doctor, but he was also a very skilled communicator, which was Dr. Richard Besser, who's now the head of the Robert Wood Johnson Foundation. He led us through H1N1, and he then left and became a broadcaster because his communication was really great. But the government spoke with one voice at that time. And I think there's just too many voices, and I think they're sort of trying to condense that so that there could be one voice speaking. And so I'm sure he'll come out soon again, but he is tired. He is in his 80s. I wish I had his energy in my 40s that he has in his 80s. But I think he'll come out again. But I think the big picture is I think more of a desire at the federal level to speak with one voice. And so, they're probably helping everyone speak with that one voice.
And I'm glad you say that. It led to a more serious question with the Dr. Fauci question, but you mentioned it earlier in terms of the politicization of this, the business pushback right around the pandemic, and how all those confluence of things kind of interwoven into where we see things at now, where if we had a unified voice, I think, and reflect back on, maybe we would have been at where we are much sooner. But that's neither here nor there. And like you used earlier, we're not in a perfect society. So, all right. So I won't hold you anymore. I know you've had a long day. Any of my council colleagues, no, it looks like we are all good. So thank you everyone for attending tonight's meeting. You could be anywhere in the world, but you chose to be here with us. So,
it's so much fun.
Yes.
John, did you happen to see my comment in the chat?
I did.
Yeah.
Okay.
All right.
I'm on it.
Yes.
I'll hit my unmute button faster.
All right. Take care.
Thank you.
Take care, everyone.
Have a great night. Thank you.
Bye.